is Gerie DiPiano, and you are listening to the Love Mia Vita podcast. My co-host is Dr. Katherine Sherif. And for those of you that haven't met Katherine Sherif, I'm going to have her share some of her background with you. She is a professor of medicine at Thomas Jefferson University. But Dr. Sherif, Katherine, please share with our guests a little bit about your background.
Thanks, Gerie. It's great to be here. So I'm an internist in Philadelphia at Thomas Jefferson University. And one of my great interests is cardiovascular disease in women. I really like helping women identify their risk factors for heart disease and helping them turn this around.
So, as you might imagine, today's podcast is about women and heart health. Now, we know that there is Heart Health Month, but Heart Health Month is every month. It's just not in the month of February. It happens to be a major issue for women. And in fact, what we understand is cardiovascular disease is the leading cause of death for women in the United States. And we understand as well that there are certain women that are at greater risk for cardiovascular disease, and they happen to be women who are in the menopause transition. But not all is doom and gloom, because there are some things that we can do to forestall the impact of cardiovascular disease and improve our cardiovascular health. And we can be aware of the sorts of things that can be done, even from a diagnostic perspective. You're going to hear this from Dr. Sherif, who has some great tips to share with women on health, cardiovascular health in the menopause transition. So let's get started. First of all, we know from studies that have been done, one in particular, which is something called the SWAN study, or the study of women's health across the nation, that there is a notable increase in cardiovascular disease during midlife. And this is because of hormone changes. As you might imagine, the decline in estrogen. And then we see some alterations in our body composition, in our lipid profile, and in measures of cardiovascular health in general that increase postmenopausally. But there are some strategies that we can undertake, and we're going to cover those. So let's talk about some of the menopause characteristics that are relevant to cardiovascular disease, and especially who are the women that are at risk. One of those issues is the age at menopause. So what do we know about the onset of menopause as it relates to cardiovascular risk?
Well, we know that the younger you experience menopause, the greater your risk for heart disease. And menopause is defined as 1 year after your last menstrual period. So if that occurs before age 40, you have premature menopause, and you are a decade ahead of everyone else. And those women go on to get heart disease at younger ages. But even if you're 45 and you experience menopause, meaning lack of or an absence of menstrual periods for 1 year, you still have a higher risk than if you have menopause at age 50. And the later you go before menopause, the more protected you are.
So we think about this in terms of natural menopause, and the data are pretty clear that this is a case of natural menopause. But there are those women who enter chemical menopause or surgical menopause. Let's talk about that, because that's the type of menopause is also important to recognize.
Yes, so having menopause happen abruptly, meaning your ovaries aren't producing hormones anymore, either because they're surgically removed or because you have, for example, chemotherapy, which has destroyed your ovaries, it plunges you into menopause. You suddenly have no estrogen and progesterone. And compared to natural menopause, That's which is a gradual process over many, many years. Starting around age 35, your estrogen and progesterone start to go down little by little, right? So we have maybe 10, 15 or more years of our sex hormones decreasing, as opposed to one day you have sex hormones, the next day you don't. And it does plunge you into this very abrupt menopause.
So when we're thinking about where we are in terms of our stage of menopause, and I know that, we don't want to over test or compulsively test, but obviously, if you have been thrust into menopause, in addition to some of the other diagnostic tests that you may undertake, what advice do you have for those women in terms of assessing their cardiovascular risk if, for example, they are either in early menopause, early natural menopause, or they are in menopause due to surgical or chemically related menopause?
Sure. So the question is, how can you assess your risk?
Yes.
Okay. If you're going, if for some reason you're having surgical menopause, it could be something that you have the BRCA, the BRCA mutation, and your risk of ovarian cancer is high. And so you've planned to have an ovariectomy. You really do need to discuss with your doctor, what do we do after this once my ovaries are gone? So that you can plan ahead for. Same thing if you are planning, if let's say you have breast cancer and you're planning to have chemotherapy and it is going to destroy your ovaries, you can actually plan ahead of time. You don't have to wait till you feel rotten. So the things that happen when you're over, whether this is natural or an abrupt menopause, is your estrogen goes down. And when your estrogen goes down, you become more salt sensitive. So what that means is, if you're salt sensitive, it means if you eat a bag of potato chips and you are not salt sensitive, okay, you absorb, you have extra salt, you might be extra thirsty that night, maybe your hands are a little tight in the morning from all the fluid that you retained fluid because you ate so many potato chips. Now, if you're salt sensitive, you absorb all that sodium and your pressure goes up. So estrogen protects us from being salt sensitive. We're salt insensitive unless our estrogen goes down, and then we're very salt sensitive. Now you eat the same bag of potato chips and you save every single bit of sodium, water follows, the tank fills up, and the blood pressure goes up. So you may become hypertensive while you're in the menopausal transition, or if you have an abrupt menopause.
That's a great way to describe it. I've never thought about it in that way, Katherine, but it does make sense. And I think for women who are listening to this or viewing this on YouTube, it probably is a good way to appreciate what happens with our bodies, and especially what happens during the menopause transition in terms of the interrelationship between estrogen and salt and some of the predisposing factors that increase cardiovascular risk. We often hear that during various stages of menopause that our high density lipoproteins and our low density lipoproteins will start to change. Our triglycerides will change. They will peak during peri and early menopause compared to premenopause. How dramatic are these changes? How dramatic should we anticipate them to be? And what can we do to help to control some of this?
Sure. So LDL, as you know, is the bad cholesterol, and HDL is the good cholesterol. And a good way for our listeners to remember this is with HDL, high density lipoprotein, you want it to be high. And for LDL, low density lipoprotein, you want it to be low. LDL is the substance, the fat that is deposited in our arteries and starts to block the arteries. And it really does go up after menopause. And we know that it's closely related to estrogen, because if you were to give someone estrogen replacement therapy, the LDL goes back down. And HDL also goes up with estrogen and goes down. HDL goes down with smoking. And in fact, I can look at somebody's blood tests before I walk into the room, before I've ever met them, and know whether they're a smoker or not based on what their HDL is. So a good HDL is like 50 or 60, and smokers will be around 20 or 30. That's extremely low, and that's our protective one. But that brings up another risk factor, which is if you're a smoker, you have to stop. And this is not blame or shame time. You just need to stop. Women don't need any more blame or shame about like how bad they are and their behavior and how, overweight they are, blah, blah, blah. They hear all this all the time. But if you do smoke, please stop right this minute.
I like the stop the shame and the blame, because you're right. We often hear this. We often understand that, yes, there are metabolic changes that take place. Sometimes they take place before the menopause transition. Sometimes we tend to go through periods of life where that is the way in which we handle stress, depression. It could be any number of factors that compel us. Could be the medications that we're taking. There are certain antidepressants that will put weight on women. So you're not going to stop taking your antidepressant because you gain weight, but then that may predispose you to some other risk factors as you continue through the menopause transition. No blame, no shame. There are ways in which we can all deal with these types of issues. And that's really what this is all about. We're about trying to help women to navigate through this, to better understand what's going on with their overall health and how that can improve the transition through menopause, because menopause should be a liberating time of life. It shouldn't be all doom and gloom. But we need to not bury our heads in the sand, and we need to appreciate that there's a lot going on here, and there's a lot going on there as a function of a decline in estrogen, but there are ways in which to address what those changes are and how that impacts our overall health. And in this podcast in particular, it's our cardiovascular health. So we look at endogenous estrogens and the impact of endogenous estrogens. Let's first of all, perhaps you can define endogenous estrogens for our listeners, because I don't want anybody to have to take out a medical dictionary. So what are endogenous estrogens, and how do they impact cardiovascular risk factors?
Sure. So endogenous estrogens means the estrogens that we produce in our body. So estradiol is the most important one. It's also, we refer to it as capital E2. And it's mostly produced in the ovaries. The second most important type of estrogen is called estrone, and it's made in our fat cells. And so when you gain weight, those fat cells, they're not just like a depot for fat to save energy. They actually produce estrone. And so again, the most important one is estradiol, and estradiol is what gives us a waist. And so when you have an absence of estradiol, that's why as we get older, we lose more and more of our waist. And then we begin to, when we gain weight, we put it in the middle. Endogenous estrogens are estrogens that we make, as opposed to exogenous estrogens, which would be either hormone replacement therapy or from things like contraceptive pills.
So if you're a woman who has higher estradiol levels, would that be a factor that would be beneficial to you, or would that be harmful to you?
Theoretically, if you have a higher estradiol levels, you have a later menopause, which is more predictive. We know that when you put pure estradiol into the arteries dilate, and you are less likely to build up plaque in there. For example, LDL, which we discussed, is the bad type, one of the bad types of cholesterol. By itself, LDL isn't too bad, but when LDL is oxidized, meaning it's had an electron ripped off it, it becomes an atherogenic LDL, meaning it wants to build plaque in the arteries. But when you have estrogen, you have a lot less oxidized LDL. So besides, so estradiol, it causes your blood pressure to come down. So when women are on hormone replacement therapy, and this isn't saying that you should be on hormone replacement therapy, but what we know is when you take hormone replacement therapy, actually, when you take exogenous hormones that look identical to our endogenous hormones, your blood pressure comes down. As we get older, the walls of our hearts thicken, and it's analogous to hypertension, to thickening of the walls of arteries. Again, if you take hormone replacement therapy, or if you look at the hearts of women who are the same age, same weight, same everything, but one's on hormones and one isn't, the heart size is actually a healthier, smaller size.
Interesting. That's very interesting. There was again, in the SWAN study, there was information that looked at women with higher estradiol levels before the final menstrual period, and they saw that they were less likely to develop, in this case, it was plaque in their carotid arteries. So it does make sense. Now, again, this information is still being collected, and much more research is needed in terms of how these factors impact women through the menopause transition. But we are accumulating a lot of information in women and looking at ways in which we can mitigate some of those risk factors through some of the changes in our behavior, through identification with diagnostic work and so forth. And we're going to get into that a little bit later in the podcast, because I know you have some really important information to share with our listeners in terms of how can you assess what's really going on. And even if you're not paying attention to your heart right now, what we hope you will do following this podcast is to amortize the information that you may have gathered from other types of diagnostic tests to actually inform you about some of the underlying risks or lack thereof. So we'll get into that in a little bit. I want to talk a little bit about vasomotor symptoms. And we had our last podcast, we talked about hot flashes, and is there a relationship between hot flashes and cardiovascular disease? So if I'm having, 10 hot flashes per day, should I be worried that that might be an indicator, or is that something that would predispose me to a higher cardiovascular disease risk?
I think the jury is still out. It's controversial. So some researchers postulate that more hot flashes are a risk factor because your estrogen is going up and down and it's not a smooth curve. And other people say it doesn't matter.
So it perhaps is what's more relevant here is when you start to experience hot flashes and when you stop menstruating, because the two would suggest that you are in early menopause. So you might have had your first hot flash, may or may not have coincided when you ceased having your menstrual cycle, but it could be a sign that you were in very early menopause, even pre-menopause, but still having some of these symptoms. So perhaps that is something to pay attention to.
Sure, because you can have your period every month all through your 40s. But if you started with your hot flashes at 42, that is kind of early, and that's worrisome, that you would already have an ovary that's kind of sputtering out.
So something to pay attention to, but again, somewhat inconclusive. So we talk about, so where is there conclusive evidence? Where is there sort of speculative evidence? And as we keep saying, and we're studying this in women, particularly in women in the menopause transition, and there are massive studies that continue to be undertaken to better appreciate how we can ameliorate some of these symptoms and reduce risk. Sleep is something that was also studied as a risk factor. And we talked about sleep in one of our other podcasts. We know that insomnia is a huge problem, not just for women, but for men as well. But in women, lack of sleep, disrupted sleep, is a predisposing factor for cardiovascular disease. So let's spend a little bit of time talking about sleep and CVD, cardiovascular disease.
Sure. So, and it isn't within the lack of sleep, there may be several different categories that lead to this, that increase cardiovascular disease risk. I'll start with the one risk factor that is overlooked in women all the time, and that's obstructive sleep apnea. So we know that women who have sleep apnea are not necessarily overweight, but they may have more testosterone than other women. And testosterone can cause sleep apnea by directly affecting the brain and the center that makes you, that controls breathing. And if you don't sleep, if you interrupt your oxygen hundreds of times a night, and you have no idea, what you do is you increase the blood pressures in the lung, and you put yourself at risk for heart failure. And what also happens with a lack of sleep, whether because you're just not a great sleeper or because you have sleep apnea or both, we know that a lack of sleep causes or worsens insulin resistance. So now when you, instead of being sensitive to insulin and only needing a little bit of insulin with a meal, now you need a large amount of insulin for a meal, and you still metabolize your food. But the problem is that insulin resistance is associated with a lot of inflammation, more inflamed LDL, more atherosclerosis, more insulin resistance. You put weight on in the middle. Anyone who puts weight on in the middle becomes more insulin resistant and produces more insulin, and it's a vicious cycle. People underestimate sleep. Women, because we have 2.5 jobs instead of 1 job, that they shave time off their sleep rather than shave time off their kids or time off work. And so they shave time off sleep, and we pay, and I believe it is associated with early death.
So given that I'm a poor sleeper, and given that this morning I had to be ready for an 8 a.m. Zoom call. I was up at 5 o'clock in the morning, and I didn't go to bed earlier. Because I was working on other things, doing some research. So of course my bedtime was the same. I just cut back on my sleep. So
that's right.
I need to work on, and I'm guessing that a lot of our listeners are probably in the same boat. Hate to say it, but that little green boat is full of us, right?
Yeah. Sleep is incredible. Sleep is medicine.
So when we think about sleep, natural ways in which to develop good habits with sleep, natural products that we can use to help us ameliorate our sleep. But that's a subject for yet another podcast. You can certainly listen to the one that already exists. It's actually in the Love Mia Vita podcast repository. But Dr. Sherif and I are likely to do another one on sleep and how to improve that. We also talked about central visceral fat, and every one of us, when we enter menopause, and I'm there, I'm menopausal. When we think about our bodies and some of the changes in our bodies, some of these changes are natural. Gravity may take over, and as much as we love to work out and try to watch what we eat, we do see changes, and it's okay. We're not here to body shame anybody. But one of the things that you mentioned was the accumulation of what is referred to as central visceral fat. We all know what that is, or we should. So that's, you had a waist at one point. Now all of a sudden the waist begins to shrink. And even a person like me with chicken legs and chicken arms starts to, and a low BMI, may start to see that it'd be nice to have that old waist back again. And that's a sign, right?
Yes, it is a sign. So as we get older and our estrogen starts to go down more and more, we instead of putting weight on in, say, our thighs or our behind, we start to put it on in our belly, and so do men. And it's a sign of less hormones and more insulin resistance. And it's also a sign of getting older, but it is difficult to tease apart what part is estrogen and what part is quote unquote getting older.
So it's just something to be watchful. If
Yeah.
you start to see it, changes that are more dramatic than you had once appreciated, or if you're experiencing more stress and your cortisol levels are rising and you are gaining weight around the middle, perhaps it's a good idea to investigate a little bit more so, because it may not only be a function of gravity or just aging or what have you. And it doesn't matter how many sit-ups or crunches you do, it's probably something to explore more fully. Depression is also another risk factor that was identified. And is depression, is it a function of perhaps treating depression, or is it a function of not treating depression? What is the relationship between depression and an increase in cardiovascular disease?
Yeah, so I'm not sure we can quite draw a straight line between depression and cardiovascular disease, that, depression causes it, but they're certainly related. And people with cardiovascular disease do have more depression and vice versa. One of the ways we could look at it is that depression, increasingly, we're looking at it as less about serotonin and more about inflammation in the body, inflammation from the gut, from the intestinal microbiome. So the bacteria that live in your gut may very well be responsible for your mood. And if you have this kind of bacteria, maybe you have more anxiety, panic attacks, and this type of bacteria, more depression or bipolar or schizophrenia. So much of it is in the gut. Anyway, the bad bacteria, they do create inflammation, and then inflammation, it makes the blood vessels unhealthy, and you're more likely to build up plaque. So I can sort of draw a dotted line between them, with inflammation as the intermediary.
So if you are experiencing depression, by all means, you should see someone professionally to address those symptoms. And we know that depression can be exacerbated during the menopause. And sometimes it's exacerbated because we see, again, the decline in estrogen. If it was present before you entered menopause, that's probably something that, if it's been untreated, you should continue to explore that and ways in which you can address those symptoms, because it could have an impact. As I think what I'm hearing, it could have an impact.
Yeah.
If you are on antidepressant therapy, perhaps you should also be more vigilant about taking the appropriate steps to measure your metabolic profile, to be certain that it's not impacting your metabolic profile, because there are changes that can be made, and you should let your psychiatrist or your prescriber know whether you are starting to see changes. Does that make sense?
Yes, it does. It does.
And again, by no means should any of what we are sharing with you today replace any of the advice that you will receive from your healthcare provider. We are not prescribing medicine. We are only here sharing information. And in the case of Dr. Sherif, who is a board certified practitioner of medicine, she is just providing information, and you should be sure to visit your provider, because he or she is the best person to make recommendations about diagnostic tests and any other lifestyle changes that you would want to make. So there are some things that I did not appreciate that Dr. Sherif shared with me when we were about to do this podcast. And Katherine, there was an example that you shared with me that I think is particularly relevant to our target audience of women here. And it really has to do with perhaps some unrelated medical issues that may give us insights into our cardiovascular health. Perhaps you want to share the example that you shared with me.
Sure. So, for example, just this afternoon, I saw a patient who she has an adrenal gland problem. And as you know, the adrenal glands are small, little pyramid shaped type glands, and they sit on top of each kidney. And so her doctor ordered a CAT scan of the abdomen to look at the adrenal glands. And so I went back to look at the study, and what I noticed is that the radiologist had written in the report, not in the summary, but in the report, that the blood vessels had a lot of atherosclerosis. And this woman is only 47 years old. And the reason they know, the reason it's obvious she has atherosclerosis is that anywhere where you have plaque, and that's the buildup of the LDL cholesterol, which causes a blockage of the arteries or atherosclerosis, wherever you have that, calcium follows. And you can see calcium on any x-ray. It looks like white chalk. And so if you see a blood vessel that has white chalk in it, you have atherosclerosis. And you wouldn't expect to see that on a 47-year-old woman. And no one had mentioned it to her. And if you read the summary of the report, it says the adrenal glands are normal, end of report. But this is something we come across a lot, where we look at radiology studies, either MRIs or CAT scans, say you had pneumonia and you had a CAT scan of your lungs. Well, you know, they do see the heart in there, they do see the aorta and other blood vessels, and they can tell you if there's atherosclerosis in there or not. So it's really important to go back to those studies and make sure your doctor reads it from top to bottom and lets you know if there is any atherosclerosis in there, because that's like getting a free cardiac catheterization.
I was just going to say it's bonus points, right? So,
Yeah.
it's, you know, sometimes we want to bury our heads in the sand and we may not want to know because knowledge,
Yes.
sometimes the knowledge is scary. In this case, the knowledge is helpful, and it is bonus points, because if you are you're having kidney stones and you had to have a CAT scan to make sure that things were looking okay, but they're saying all of this and you've already paid for that scan. And it's great information. You can act on it, or you can choose not to act on it. Hopefully, there is nothing remarkable in there to indicate that you have any cardiovascular issues, but wouldn't it be wonderful to know in advance that there was something that could be done in order to make a change? You could make a lifestyle change. And you learned that coincidentally.
Yes.
You learned about that coincidentally.
Right. I mean,
Something
it's
important.
Insurance doesn't cover a test to look at your coronary arteries and say whether or not there's atherosclerosis in there. So what we're supposed to do is have a heart attack, and then you have a catheterization, and then we find out whether there's a blockage or not. So this is free information. It's really important. You can act on it, and you can turn this around.
So we've spoken a lot about the different risk factors, things that happen to our bodies during the menopause transition. What are the 3 things that we should take away from this podcast that are really more solution oriented, that can help with our cardiovascular health? Because that's really the point of this, is know what the risk factors are, understand how to mitigate some of the damage. If you're younger and you're listening to this podcast or you're seeing it on YouTube, it's an opportunity for you to take control, maybe assess where you are, think about how you may need to change your diet, understand what medications you're taking. if you're consuming a lot of alcohol, if you're a smoker. I think we heard all of these things during the podcast. You can start to make those changes before you enter the menopause transition.
Yes. So number one, know what your risk factors are. So we can list them all in one place, which we've just been touching on them. Number one, risk factor: are you a smoker? Number two, did your mother or father have a heart attack at a young age, say under 50 for a man, and under 60 for a woman? So that's family history of heart disease. Number three would be, do you have diabetes or are you pre-diabetic? Number four, do you have high cholesterol, meaning high LDL cholesterol or high triglycerides, not the HDL, the good one? And then number five would be, do you have hypertension? Now, there are other risk factors that are just as important, but they're not the five that are always listed. The other one that's most important would be, are you sedentary? Because our sedentary jobs are killing us. So that would be number one, is assess your cardiac risk factors. Two, speak to your doctor about what you can change. And I guess we really should throw sleep in there, and don't discount the importance of sleep. And then number three, well, when you address them with your clinician, then you can decide, what do you need to do in terms of diet? What do you need to do in terms of exercise? And we talked about this before. When you're in your 30s, you feel like you're immortal. And then when you're 40s, you're wondering, maybe you are going to die. And then later on, you're going to die. But when you can use this time of life where you assess your risk factors, like, what are you going to do to change this, to turn this around? And it almost always comes back to diet, nutrition, exercise, and sleep.
That's good advice, Katherine. This has been very helpful. It's been helpful to me. I did not appreciate the other point that you made about taking advantage of opportunities. If you unfortunately had to have an MRI or a CAT scan due to another medical issue that you were facing, that information is good information. Don't disregard that. Make sure that your healthcare provider, clinician reads through the entire report, and if he or she notices anything that is untoward, make certain that you are made aware of it and can act on it. Yeah. And that was really great advice. So thank you for sharing that with us. The podcast that we're doing today is a podcast that we will likely continue in terms of providing additional information regarding health, particularly cardiovascular health, because it is such a key issue for women. As stated in the beginning of this podcast, cardiovascular health is so important in women because we can change this trajectory if we take this issue seriously, and I believe that we are. The American Heart Association has certainly done a wonderful job of spending and investing a significant amount of time speaking about women and heart health. But we intend to do more of that on the Fem Pharma Love Mia Vita podcast, because we do remember that one in five women even worse, will be a casualty of cardiovascular disease. On the happy note, we are going to continue to provide you with information and resources. And we're pleased to have Dr. Katherine Sherif as my co-host. As you can tell, she's an expert in many areas. She has a philosophy that I believe needs to be embraced in women's healthcare, and that is taking control of the total woman and not simply just the reproductive organs of women. So
Thanks,
Catherine,
Gerie.
it's always
That's
a
great.
pleasure. Thank you for
Thank
being
you.
my co-host. And we look forward to many more episodes. Hopefully we've enlightened you today. We want to thank you for joining us. All of you, take care, be well, and love Mia Vita.